neuroleptic monitoring syndrome, especially sensitive patients. So, as far as the monitoring of analgesia and sedation is concerned, the assessment is most reliably monitored with visual analog score, VRS, and NRS scores. And then, there are brief pain questionnaires also available. And then we should also be able to assess sensory, affective, and behavioral components of the pain. And behavioral physiological scale also will help us to assess the severity of the pain. So, especially if the patient is intubated, the facial expressions, okay, movement of the upper limb, and compliance with the ventilator, whether the patient is fighting with the ventilator, these parameters can be assessed. But if the patient is not intubated, the facial expressions and this movement of the upper limb and vocalization, and okay, after giving pain, how the patient is, these responses can be monitored for assessment of the efficacy of the sedative agent. So, Riker sedation agitation score and Ramsey sedation score is most popular, but Vancouver interaction and calmness skills are also available, which are also called as comfort scale. So, as far as Ramsey sedation score is concerned, the target is to keep the patient in the sedation score of 3, where the patient responds to commands only. Okay, the patient, if the patient is anxious, agitated, probably this patient is not safe. This patient needs to be sedated. But the patient should not be deeply drowsy or not responding to commands. Should not be like that. Okay, so objective assessment of the sedation is with the help of assessing the depth of sedation with the help of neuromuscular blockade, observable behavior, heart rate, esophageal contractility, lower esophageal contractility, and EEG can also be used, as far as the sedation assessment is concerned. And whenever the patient is on sedation infusion, daily interruption of sedation is very, very important. Studies have shown that daily interruption of sedation has led to reduction in the hospital length of stay and overall expenditure, and morbidity and mortality also has been reduced, and neuromuscular dysfunction is also prevented. So we can reduce the length of stay by 2.4 days, and 50% reduction in the dose requirement can also be reduced if you use the sedation score also. So that's why we need to assess the pain. We need to assess patients' pain and the sedation more frequently. Okay, and then we should be able to choose the stronger analgesic agents, especially in patients with the severe pain. And as far as sedation is concerned, sedation has to be started along with the analgesia. And the propofol, like sedative agents, can be useful when we want the sedative effect for short duration. Okay, and the midazolam should be recommended for short-term usage. But when you are using it in a continuous infusion, make sure that these patients will have prolonged sedative effect, and we should titrate the sedative dosages of the drug with the help of Ramsey sedation score. And then to touch about neuromuscular block, basically it is used to facilitate intubation and used in patients on mechanical ventilator and control of ICP and prevent muscle spasm and reduce oxygen consumption. So depolarizing and non-depolarizing muscle relaxants are there. Vecuronium is commonly used, drug which is non-depolarizing agent, and it has prolonged action, but it has a steroid action and it can cause neuromuscular weakness. Rocuronium is a rapidly acting muscle relaxant, and it has a dose range of 0.6 to 0.1 milligram per kg, but only 5 to 10% of it is metabolized. Atracurium is quite safe, and it can be used in kidney and liver failure also, because it gets metabolized by ester hydrolysis. But the only problem is histamine release, and some patients also can have bronchospasm. Monitoring of neuromuscular blockade is with the help of TOF stimulation score, where you have to apply the 2 electrodes, and you have to give small, current electron, where the muscle twitching is analyzed. Okay, the complications of a neuromuscular blocking agent is, critical illness myopathy, and the neuropathy is also seen. So that's why TOF monitoring will be very, very useful. If we are using steroid related muscle relaxant, these are notorious to cause these problems. And this should be contraindicated in patients with neuromuscular disorders, and Basically, it should be, the intention should be is to just to achieve intubating condition, or if the patient is fighting on ventilator, for prevention of patient ventilator dysynchrony. For short-term usage, this can be used. This can also be used in continuous infusion, but for not for prolonged duration. As far as possible, the neuromuscular monitoring with the help of cough should be used to prevent the complications associated with these agents.